Hello, good evening, everyone. You're welcome to another webinar on skin NTDs. My name is Dr. Folakemi Cole-Adeife, consultant physician and dermatologist at LASUTH. So welcome, everyone. We changed the time a little bit today. Initially, Dr. Oiwo was meant to be presenting endemic treponematosis, known as yours, but he is unavoidably absent on official duties in Abuja. So he is unable to take that presentation today. So I will be taking another presentation on Mycetoma or Madura Foot, which was meant to be the next presentation, but I'll take it today because Dr. Ewo will not be able to join us at the moment. Thank you everyone who has joined in this series. I hope it's been beneficial. I hope it's been useful. And don't forget that if you have any cases, if you see any cases, don't hesitate to contact us. We're still trying to get the app to be functional, but it should be functional, before the end of this month. And you can try sending photos, or if not, you can just send an email to me at the registered email on the links, when the registration links are sent to you. Don't forget that if you have any questions, you can put them on the chat box or the Q&A section, and we'll join you. We'll answer the questions. So let me try to share my screen so we can start. Okay, let me just put this up. Okay. I don't know if Dr. Gold is joined in. Dr. Gold, Dr. Abdullahi, and Dr. Oiwo were the facilitators, and myself, Dr. Adeife. Let me just let them know that we started while I share my screen. Okay. So we're going to be talking today about mycetoma. Mycetoma is actually a rare condition, but we still do see mycetoma cases from time to time, and it's commonly known as Madura Foot. So we're going to be talking about mycetoma. I'm sure when you see the photos, you probably have seen someone with something similar. There are many differentials, though it may not have been mycetoma, but it's just for us to have a very high index of suspicion when we do see someone with that presentation. Dr. Oiwa, you're on the road, right? I think your audio is on. Yeah, thank you. So let me just see. I hope you can hear me. I hope I'm audible. Am I audible, and can you see my screen? Hello?
Yes, you are. Your screen is right.
All right, thank you. This webinar series is brought to us by the Nigerian Association of Dermatologists and is sponsored by the International Foundation for Dermatology and the International League of Dermatological Sciences, ILDS. We're thankful to them for this. So this is the outline that I'm going to be sharing on Madura Foot introduction, the classification, epidemiology, pathogenesis, clinical features, complications, investigation, prevention, and treatment. And then at the end, I'm going to discuss a case report that we managed recently in our hospital at LASUTH. So Madura Foot or mycetoma is a localized chronic suppurative deforming granulomatous infection that is seen usually in tropical and subtropical areas. Suppurative just means that it produces a lot of pus. And it is one of the neglected tropical diseases, though rarely it's not as common as some of the other ones that we've discussed, like leprosy, onchocerciasis, leishmaniasis, and others. But it is, there are cases of this being reported, and the global consensus is that cases of Madura Foot or Mycetoma are underreported, meaning that a lot of these cases go undiagnosed. And it's usually a disorder of the limbs, mainly the feet, and it involves all the layers, including the skin, the subcutaneous tissue, the muscles, and the bones. And it's characterized by a triad of swelling, sinus tracts, and production of grains or granules. Now, mycetoma can be divided into two main categories. You have the Mycetoma and the actinomycetoma. Mycetoma are caused by fungi, and they constitute about 40% of mycetomas, while the actinomycetoma, the second type, is caused by bacteria, and they are more common with about 60% of cases. So the treatment of these two types of mycetoma is different. So it is important for a definitive diagnosis to be made. And that means that microbiological examination is mandatory. So if you're seeing a case of mycetoma in a rural area, that person, and you don't have microbiology lab facilities, you will need to refer that patient to where they can have those investigations done to ascertain the type of mycetoma it is, so that the treatment can be appropriate. So mycetoma is notoriously difficult to treat, even where you have a definitive diagnosis. In many cases, it tends to be recalcitrant to treatment. And the mycetoma, which is caused by fungi, is usually unresponsive to standard antifungal therapy. And often, in many cases of mycetoma, the end result has to be, or the last result has to be, amputation of the affected foot or limb. And in some cases, actinomycetoma does respond, but it's very slowly responsive. So you're treating the patient on antibiotics for 6 months, 7 months, 9 months, and it's really long. So the etiology, mycetomas are caused by various species of fungi and bacteria. The fungi usually are the actinomycotic species, like actinomadura, actinomadura madurae, actinomadura pelletieri, and then you have the Nocardia species, Nocardia brasiliensis, and then you have the Streptomyces species. So the Streptomyces, the Nocardia, and the Actinomyces are the bacterial or the actinomycotic mycetoma. While for the fungal, the mycetoma, you have the P. boydii, the M. mycetomis, and M. griseae. Those are the causative organisms for the fungal mycetomas or mycetomas. So it has been discovered that some organisms are more associated with healthy and immunocompetent individuals, while others are found in people who are immunosuppressed. Nocardia species are usually found in mostly affects immunosuppressed individuals. So so you have the Madurella mycetomatis. That is the causative agent in mycetoma. That's the most common, but you have also the Madurella griseae and a few other rarer ones like the Leptosphaeria senegalensis and a few other ones. And how they are differentiated are by the type of grains or granules that these mycetomas produce. So clinically, you could have either the patient could have black grains, red grains, that you actually see them coming out of the wounds and the sores, and the white to yellow grains or the red or pink grains. So different types cause, usually black grains are found in the mycetomas, while red and pink grains are found in the actinomycetomas. White and yellow are seen in both. So white and yellow will not help you to distinguish between the eumycetoma and the actinomycetoma. But if you have black, you are thinking, okay, more of a eumycetoma. And if the person has red to pink, you're thinking more about actinomycetoma. So mycetoma occurs worldwide, but it is endemic in what we call the mycetoma belt, which is in some tropical and subtropical regions. You can see here where this green bar is in the world, and that's where you have most of the mycetoma. But these countries in green are countries where cases of mycetoma have been reported. So it shows that even though they are outside the mycetoma belts, they've still reported cases of mycetoma. So it's not that it doesn't occur there, but it tends to be more common along this mycetoma belt. And it is found to be much more common in males than females, with a ratio of 4:1. And usually the patient with mycetoma is a young male adult between the 3rd and 4th decade, and we will explain why this is so. So talking about what the cause is of the pathogenesis, you have some antibodies against some of the causative organism. They are found in a number of individuals, but only few develop the disease. So even though many people can be exposed, but not everyone exposed to these organisms will go on to develop a mycetoma. So it is thought to believe that the cause of mycetoma is a complex interplay of factors between the host and the pathogen. And usually what happens is that the organism, the microorganism is implanted into, the tissues, usually the feet or the hands, from a penetrating injury. And this usually is sustained in farmers who are involved in, subsistence farming with agriculture, and they work barefoot on the farms. So they are more likely, to come in contact with these organisms in that environment, or either that, or there's a pre-existing injury, and then they come across, or that injury gets infected. So from trauma, from wood, from the soil, and the organism enters, and there are some predisposing factors, like I said, like decreased use of shoes, also tropical or climate weather is associated with this, and poor general health. Also malnutrition, because what we find is that our innate immunity usually is able to engulf and inactivate or control these infections these organisms when they enter into the body. But in people who develop Madura Foot, that innate immune protection fails, and then T-cell responses, that's lymphocytes, T lymphocytes also, play a role in the development of mycetoma. So what happens is that the first line of defense fails, and then the second line of defense becomes exaggerated. So you find that a lot of, the T-cell lymphocytes are involved, and there's also a lot of neutrophilic involvement. That is the neutrophils. These are types of white cells. So you also have 3 major types of immune responses that lead to mycetoma. The type A is one that is caused by neutrophilic degranulation, and then this causes, and then there's adherence of the grains to the surface. This is why there's so much suppuration, because neutrophils would result in the formation of pus. And then outside of the zone of the neutrophils is the zone of granulation tissue, which contains macrophages, lymphocytes, and plasma cells. And all this, contributes to the inflammatory response that results in the mycetoma. And of course, there's also the type B and C. Type C, you have the formation of epithelioid cell granulomas. Type B is where you have the arrival of macrophages after the disappearance of the neutrophils, and then you develop the granulomas in type C. So this is what a Madura Foot looks like. This is a picture from the internet. They usually have a triad of painless, woody, hard swelling, discharging sinuses and grains. So you can see it's very, it's a very terrible skin and soft tissue condition. You can see, sorry about that, you can see draining sinuses, and also there's some blood. You may see some grains as well, and the leg is usually, or the foot is typically not so painful, but by the time it starts bleeding, it becomes very painful. So in the early stages, there may just be some tiny bumps or papules. And then later on, those become larger and become nodules and pustules. Pustules meaning they begin to discharge pus. And these pustules later rupture and coalesce, forming sinuses. So you have sinus tract formation. And then the common sites, include, like I mentioned, the feet are the most common sites. And then the arms, you could have them on the arms, the legs, but rarely would you find it on the head and neck or in the groin and the buttocks. So it's usually a disease of extremities, in few occasions on the trunk, but very rarely, usually on the feet, on the arms, and on the legs. So there are also some unusual presentations. It may, become lobulated. You may have what we call verrucous plaques, which is very scaly, hard plaques on it. And it could just be a painless swelling. There may not be discharging sinuses. Some may present just like an abscess. They may have itching, and about 20% of people experience pain. The skin with a mycetoma is usually darker, and it's usually thick, very thickened. So a lot of people, may not be able to distinguish between early onset elephantiasis or lymphatic filariasis and mycetoma in some cases, but there are things that you can use to distinguish. Usually the discharging sinuses and the granulation, you think more of mycetoma. And then mycetoma is usually limited to the foot, whereas elephantiasis or lymphatic filariasis will extend up the whole leg in most cases. So mycetoma is also associated with a lot of secondary bacterial infection, as you can see, as you can understand why you have open sinuses everywhere. So aside from the causative organisms, the actinomyces species, you may have other secondary bacterial infection that further complicates and worsens, the mycetoma. So that can be there. Of course, it can go all the way into the bone, causing an osteomyelitis. That usually is in the very severe cases of mycetoma that, usually may require or eventually may require amputation, but in very aggressive treatment, you can salvage the limb. There's often septicemia. As you know, the secondary bacterial infection can then go into the bloodstream and cause, sepsis, and that can be really terrible as well. You can have secondary amyloidosis. There can be a long-term sequelae of lymphedema due to lymphangitis and fibrosis of the lymphatic vessels, resulting in lymphatic obstruction and lymphedema. And of course, if it is not treated, it may require amputation. And then another major complication is toxicity, ototoxicity, and hepatotoxicity from the prolonged treatment with antimicrobial and antifungals that we're going to discuss later. So these are just clinical features. You could have a tumor, a single well-defined margin, usually in mycetoma, while in actinomycetoma, you tend to have multiple lobules with an ill-defined margin. Then the sinuses, in an actinomycetoma, those sinuses appear earlier on in presentation, and they are numerous with raised inflamed openings, usually with bleeding, like the photo we saw. However, in mycetoma, you have a bit fewer of those sinuses, and they appear later in the disease. Then we spoke about the discharge of the granules in actinomycetoma. they are more of red, granules, or white, while in Mycetoma, black or white. And the bony changes also differ. In Mycetoma, you have more of a osteosclerotic change, while in actinomycetoma, it's more of an osteolytic change. So these are differential diagnoses, meaning that there are other things that can cause it. I spoke about lymphatic filariasis, even though it's not on this list, but in people a lot of people have, a lot of the cases that I've seen were wrongly diagnosed as elephantiasis, but that is because probably the person was not able to distinguish between the two. Elephantiasis is more common. So once people see someone with a single unilateral swollen foot, they think of that. But there are so many other things that you use to distinguish, like I mentioned earlier. Then osteomyelitis, if there's a chronic bone infection, it can lead to sinus discharge, which is similar to what is seen in actinomyelitis. But the difference is that usually you don't have multiple sinus discharges in osteomyelitis like you see in the actinomycetoma. Chromoblastomycosis is another deep fungal infection, chronic deep fungal infection. And we're going to be talking about it on another day. And it looks quite similar to the mycetoma, but there are several distinguishing features that you can use, and of course the histopathological diagnosis. Now, actinomycosis, also tuberculosis, of the skin, but usually you will not have that. Buruli ulcer is very different from, or does not present like this. You don't have discharging sinuses in that. However, in cases of where you have lymphadenitis, or you have scrofulodema, which is a type of tuberculosis on the neck, it looks very similar to what's it called? It looks very similar to actinomycetoma, but the location is usually what will distinguish that. And then Buruli ulcers are totally different. So it's unlikely that it's tuberculosis, but some cases you may want to consider that. Sporotrichosis is also a deep fungal infection, and it also occurs in a similar manner to Mycetoma, but it also has some distinguishing features, and we'll talk about chromoblastomycosis and sporotrichosis on another day, because they are also skin NTDs under deep fungal infections. Osteosarcoma is cancer of the bone, and cancers of the bone can also present like a Mycetoma, actinomycetoma, but they will be associated with a lot of pain. They'll be associated with constitutional symptoms, usually weight loss, and the number of sinuses will be different. And then, of course, you will have granules. The granules usually are what distinguish Mycetoma from other similar other conditions that look similar to it. Podoconiosis is also a very similar problem to Mycetoma, but it's not caused by fungal infections, caused by toxins in red clay, in some kind of volcanic clay that people who farm are also exposed to in particular areas, also caused by going barefoot. And we'll talk about podoconiosis as well. But there are ways to distinguish podoconiosis also from Mycetoma. So there are so many things. So this is one of the reasons why Mycetoma should be managed by specialists. So when you see a patient and you suspect Mycetoma, it's best to refer the patient, because there's a lot of examination and investigation that will be done to ascertain if it is actually a Mycetoma or it's something else. So these are some of the investigations that we want to do, starting with the direct microscopy fungal studies with potassium hydroxide. And then, of course, there's the microbiological culture to actually culture the actual organism. We do, of course, the saccharide agar for fungi and the blood agar for bacteria. Now, the agar plates, usually it takes up to 6 weeks. So we usually don't wait for the culture to treat. If you have your skin biopsy and you have your KOH, you can start treatment. There are also some serological tests for antibodies, like the ELISA against Nocardia brasiliensis, and those are some of the investigations. So usually we order a skin biopsy, and from the skin biopsy, you may be able to diagnose mycetoma. So skin biopsy, in mycetoma, you have a suppurative granuloma with neutrophils surrounding with the characteristic grains. While in actinomycetoma, you have homogeneous eosinophilic material around the grain in a star-shaped manner. That's the Splendore-Hopley reaction. It's called the Splendore-Hopley reaction, and it's characteristic or diagnostic of actinomycetoma. So you have the staining. Usually with the H&E stain, there are different colors. The actinomycetoma has a specific color, while the mycetoma also has a color, brown color. So these are some of the laboratory investigations that we use to distinguish. Like we said, it's the aim is to identify causative agents to determine whether it's mycetoma or actinomycetoma, because even though the clinical features could be slightly different, we are not totally sure which one it is until you've done these laboratory investigations, and this will affect the direction of treatment. Okay, we've spoken about the colors of the grains before. So basically, the actinomycotic grains are white or pink, while the eumycotic grains are black to brown and white. So imaging, you need to do an X-ray when you have a patient suspected of mycetoma, because the X-ray will determine the degree of severity and the degree of bony involvement, and that can also affect treatment. So you want to check if there has already been, and it will also determine the type. Like we mentioned that, in mycetoma, you have osteosclerosis, while in actinomycetoma, you have osteolysis. So you want to see what kind of bony changes are there. That will also aid in the diagnosis. So usually, only 3% of patients with mycetoma will have a normal radiograph. Most will have some degree of bony changes, but in various degrees. So you may have multiple lytic lesions, they may have small numerous cavities, and in later stages, osteoporosis. And then, of course, there's a radiological staging, which is not really necessary for this talk. But from the radiology, you'll be able to determine the degree of bony involvement. In some cases, an ultrasound can be done, where you may be able to see on the ultrasound some of the sinuses and thick wall cavities, that you see. So these are the findings on ultrasound. And the mycetoma, you have sharp hyperreflective echoes corresponding to the grain. So the granules will actually be visible. And in actinomycetoma, you have hyperreflective, closely aggregated granules settling at the bottom of the cavities. So in a place where maybe ultrasound is available, this could also be done if there's no X-ray facility available. In the management of mycetoma, it's important also to investigate the patients. You want to know their blood levels. Are they anemic? Because a lot of patients present with bleeding. So you need to be sure that they haven't really bled out too much. And then, of course, anemia affects wound healing. So if they're anemic, you need to supplement, both with diet and with iron supplementation, folic acid, and the likes. The blood sugar is essential. Elevated blood sugar is also a risk factor for mycetoma. So diabetes can be, or pre-diabetes can be a risk factor. Remember, we said not everyone who is exposed to the organisms will develop mycetoma, but if there's any form of immune dysfunction, it could occur. And diabetes is one of those things associated with that failure of innate immune response. You're doing the electrolyte, urea and creatinine and liver function test to determine that the patient does not have any preliminary renal or hepatic impairments, because those the drugs they're going to be using are going to, be tough on the liver or tough on the kidney. I want to be sure that the kidney and the liver are already in optimal condition. This will also determine how far you can go, how aggressive you can be with treatment, because you don't want to be very aggressive and send your patient into renal failure or hepatic failure if they already have pre-existing kidney or liver dysfunction. So it's important to have a baseline renal function test and liver function test. Then the mantra is to rule out tuberculosis, and then HIV, of course. Immunosuppression usually aggravates such conditions, and you want to be sure that the patient is being treated for retroviral disease if that is present. So hepatitis B and C screening is also essential. Hepatitis C is associated with a condition that is similar to Madura Foot, and you want to rule that out. So in the treatment, usually there is a combination of medical and surgical therapy. Medical therapy is often sufficient for actinomycetoma, but very, very lengthy or long-term medical therapy. Mycotomas are found to be more resistant to medical treatment, and there's often the need for surgical treatment alongside medical treatment. The most successful treatment for mycetoma has been with the azole, itraconazole, but even with that, triazoles generally, are the standard of treatment, but even with that, in many cases of mycetoma, they are not effective, and surgical intervention is required. There are other antifungals used like voriconazole, particularly for specific types. This is essential, to know. Also in immunocompromised patients, you want to go ahead with a stronger antifungal, but these liver function must be monitored very closely when using these antifungals, because they are actually hepatotoxic, particularly in high or long-term doses that they're used in mycetoma. And so this is just like a treatment table. There are different regimens that are used in the treatment of both actinomycetoma and mycetoma. There's the Welsh regimen, modified Welsh regimen, the two-step regimen, modified two-step. They're just because it's a very difficult condition to treat various things, but usually in most cases in the actinomycetoma, you're using cotrimoxazole, that's trimethoprim, sulfamethoxazole, or popularly known as Septrin, is usually the mainstay of treatment for actinomycetoma, while itraconazole is used as the mainstay of treatment for mycetoma. Now, that's just, tables on the Welsh and modified Welsh regimen. I don't think I'm going to bore you with the details of that. But for people treating mycetoma, it's important that you know these classifications. And, pharmacists also need to be aware, because sometimes when you send the patients to pharmacy with the long-term dose, they're usually skeptic. They're usually apprehensive at dispensing, those large doses of antifungals, because it's actually quite a lot. But usually, if you're treating mycetoma, you really need to have long-term and high dose, of antifungals and even some antibiotics. So we do use gentamicin if cotrimoxazole is not effective, or we use a combination of both gentamicin and cotrimoxazole. So there is quite a lot of antibiotics involved, and that's why we need to be sure that the kidneys and the liver function is normal. So other treatments include steroids, sometimes with a lot of inflammation. It is controversial. Steroids will not prolong the treatment, but in some cases, and I'll discuss with you, a case report that we had, the steroid actually helped, to reduce a lot of the inflammation, and then we stopped it and continued with the antibiotics. So short course of steroid could be helpful. Analgesia, where there's pain, most patients with mycetoma will not have so much pain, but where there begins to be severe pain, you must give an analgesia to relieve the patient's pain. And then the skincare is very essential. You need to make sure that it's kept clean as much as possible. Avoid walking barefoot, obviously. And then bleach soaks or saline soaks. So in diluted bleach, and of course, normal saline can be used to clean the external part of the foot. And of course, emollients will help the skin to repair as the healing begins to take place with treatment. So you want to use emollients, things like Vaseline or paraffin, liquid paraffin. Those are some of the things that are used on the skin. And bleach soaks. So surgical care, usually this is an option, especially in mycetoma. If the patient has not responded to antifungal treatment, usually after 3 to 4 months, you begin to think about amputation. But even before then, you could have some wide local or debulking excisions. So you may need to want to drain some of the sinuses and all that. And then, of course, amputation is the last resort. In patients with extensive disease as well, amputation is also a consideration or the end result or the last resort if you're not achieving any improvement, because you don't want a situation where the patient then becomes septic, has septicemia, goes into septic shock and dies. It's better to save the life and lose the limb if the limb is not amenable to treatment or responsive to treatment. And of course, follow up, because the medications are on for months. So treatment and follow up is usually for several months, up to a year. And of course, you have to continue to monitor the kidney function and the liver function. Also, where things like gentamicin or amikacin are used, you must also check for the audiometry, the ear function, because that category of drugs, they are ototoxic or they are harmful to the ears. So it's important for that to be done. You don't want to treat Madura Foot and the patient ends up becoming deaf. They won't thank you for that. So you have to be very cautious, because you're using some of these medications for long periods of time, up to months and months. You really, really need to monitor closely to ensure that you are not doing more harm to your patients with the treatment. Prevention is avoiding carrying sticks and thorny branches. Usually you want to make sure you wear protective shoes. So in places where you're in the soil, proper farming boots, are important. Not just wearing slippers to the farm. You have to try to use farming boots. So if you're working on the field, on sites where you may be exposed to a lot of soil, appropriate footwear and protective clothing is very essential. There is no vaccine or preventive drug for mycetoma, so we want to make sure that other forms of protection are properly adhered to, especially in at-risk populations in tropical and subtropical environments where mycetoma is endemic. So this is a case of a patient we saw in our clinic in last week, who presented with this. She was a 27-year-old, and she was a female, even though it's more common in males, but this was a female presented with this she had had it for about 1 or 2 months, and started with swelling of the foot and then the sinuses. And you can see the granules here. You can see yellowish granules, right? They're whitish and yellowish granules. So this doesn't tell us whether it is mycetoma acting on mycetoma, but it tells us that it is mycetoma. You can see the multiple discharging sinuses that she had, and some suppuration, that's the pus. And in few areas, there's bleeding. And she presented with this, right foot swelling with which was woody hard, initially not so painful, with multiple sinuses and yellowish white granules. And it was unilateral only on this foot. She wasn't a farmer. We couldn't really find any risk factor for her per se, but she did mention that sometimes she does walk around barefoot. She wasn't diabetic, and she wasn't immunosuppressed as far as we could tell. We had to do an X-ray to try and see, and you can actually see on the affected foot there are multiple lytic lesions. Here you can see here that the bone has some, light here, the patches here. You can see that these are lytic lesions, on the first proximal phalanx and the first to fifth metatarsal. So you can see that this was in keeping also with the clinical presentation of Madura Foot. A biopsy showed that she had Splendora-Hopley phenomenon. And there was a dense infiltrate of neutrophils with clumps of purplish bacteria. So this was an actinomycetoma. Now, this was the initial treatment before we got the results of the biopsy, because we were not sure if it was mycetoma or actinomycetoma. So we started her on both antibiotics and antifungals so that we could cover that until we had a definitive diagnosis. And of course, with patients with mycetoma, it's important to give anti-tetanus injections. So you want to give them a start dose of the tetanus toxoid and ATS after test dose. And we also gave hematinics because I think her PCV was low at about 30%, and then vitamin C, vitamin E to aid healing, and ibuprofen for pain relief. And then every other day dressing with normal saline. So after 2 weeks, there wasn't much improvement, and she was complaining about pain. She had a lot of pain, and then of course the biopsy results came in. So we now knew that this was actually not a mycetoma. We're thinking of an actinomycetoma. So because of the pain and the swelling, we decided to give her a short course of steroids to reduce the inflammation, and then we changed her to the modified 2-step regimen, which was gentamicin and septrin. And she did well with that. Within 3 months of treatment, this was, how the foot was, and at 9 months, this was how her foot was. So she was very happy, and we were able to stop the antibiotics after about 9 months of treatment. So she was on antibiotics. We later switched to doxycycline. So it's a long-term treatment, but if the diagnosis is, achieved, you can actually save, the foot. If this patient was not properly treated, she may have developed sepsis, septicemia. She may have required admission and, kidney, going to kidney failure, and that, God forbid, could have lost her life. But because she was able to get appropriate treatment, we were able to get that. We're happy that it was an actinomycetoma, because, like we mentioned, mycomas are usually more difficult to treat, and treatment is not as successful in mycetoma as in actinomycetoma. But the main take home is that you must, if you feel a patient has a mycetoma, please refer to the nearest dermatologist or infectious disease physician, so that that patient can have prompt and appropriate diagnosis and treatment and follow-up. So thank you. These are my references, and I want to thank everyone for listening today. Thank you so much. So that's the end of the presentation. So welcome questions, comments, and
hello, Dr. Cole.
Yes, hello.
Thank you. It's Dr. Gold.
Okay.
Hi, I was just going to say moderate and just
go ahead.
Thank
please.
You for the presentation. I joined a bit late.
That's
a bit late because my internet was acting up. Sorry about that.
Right.
Yeah. So thank you, Dr. Cole, for the wonderful presentation as always. And it was so, and I like the fact that the pictures were there to show the effects of treating the patients that have these deep fungal infections. So I've not seen any question in the, Dr. Oiwo has answered some of the questions, okay, and Dr. Abdullahi too has answered. So I don't know if there are still further questions. Maybe if there are more questions, people can leave it in the chat box, or maybe if somebody wants to unmute or something. But right now, I can't see any further questions in the chat box.
Okay, I'll just read them out what is here. Someone says, mycetoma, is mycetoma infectious? They say mycetoma is non-contagious. So no, you can't get it from someone, but you can be exposed to it. And Dr. Ewo has adequately answered that. Thank you very much. And the other question is, okay, I've seen some questions here. Someone has said, nice presentation. Thanks a lot. Thank you, Ibrahim Yusuf. How to differentiate between TB adenitis with mycetoma, since the location is different? So, like I mentioned, with TB adenitis, usually you won't have it on the extremities. You know, most of the time with TB adenitis, it occurs where you have a lot of lymph nodes. So you find it around the neck, you find it in the armpits, in the groin, where you have your lymph nodes. But with mycetoma, it's more on the extremities. So you tend to have mycetoma in the feet, in the hands, the legs. So that is one thing that would distinguish TB adenitis from mycetoma. Usually, of course, investigations and laboratory investigations will be done to this. The biopsy also will be able to make a definitive diagnosis. Of course, with the TB, you're looking for caseating granuloma and all that. So you want to look for that. You won't see caseating granulomas in mycetoma. You see granulomas, but not caseating. So that's how usually they're distinguished. The location and also the investigation findings, presentation. And then those granules usually are very, very distinct for mycetoma. So yeah, I don't know if I should show the photo again so you can see what the granules look like. So usually with other conditions, you may not have those granules. So you want to look out for that. Let me see if I can go back. Okay. So I'm just trying to look and put back the photo and the presentation. Sorry. Can you see it on my screen? Can you see the presentation? Hello, am I audible? Yes, so I want to put this photo so you can see these yellowish things here. Those are the granules. Usually you'll be able to determine that, okay, this is most likely a Madura Foot. So Taufik Suleiman is asking, what are the alternatives to aminoglycoside in case of ototoxicity or nephrotoxicity? So there are other regimens. We use cotrimoxazole for a long term, that's Septrin, and you can use doxycycline if aminoglycosides, there's ototoxicity or nephrotoxicity. Usually, you may not achieve as rapid as improvement without the aminoglycoside, but they're usually amenable to cotrimoxazole, and then at later stages, doxycycline. So those can also be used. In some cases, we use penicillin as well. We use injection penicillin V, but in more recent times, we can actually use imipenem. That's we can use meropenem, or generally the carbapenems can also be used. So those are alternatives. How do you differentiate mycetoma from actinomycosis? So usually the the location also can also be a distinguishing feature. Like I mentioned, mystomas are usually on the extremities. Then also with actinomycosis, it could be more widespread than the mycetoma. Thank you for the presentation. Does mycetoma require any topical wound care in addition to injection? Yes, so that's what I mentioned, that usually we do bleach soaks and saline soaks. So saline soaks, that's normal saline to at least prevent further infection of the sinuses. And the other thing is bleach soaks as well can be used. And then for the skin, you want to use a lot of emollients to protect the skin. So things like petroleum jelly or liquid paraffin can be used as well. So that is usually the topical wound care. We don't tend to dress the foot so much, but if it's bleeding, there can be wound dressing, but that needs to be changed at least every other day. Alternate daily wound dressing at least. So Moses said, I had a patient with histology confirm mycetoma of the right side of the face with difficulty opening her mouth. She's presently on antifungal and septrin for 3 months. What else to do since we can't? So the first thing, I mean, that's a location that is quite uncommon, but you know, in medicine, we never say never. In such a case, you want to make sure that you find out whether it is actinomycetoma or eumycetoma. You may not be there, of course, you can't amputate, but there can be some debridement. So debridement can be done. Some of the tracts can be removed. So that patient ideally should be co-managed with the maxillofacial surgeons. They probably would need to do some debridement of the affected areas. And of course, whether treatments based on whether it is actinomycetoma or a eumycetoma also. So if you want to if it's actinomycetoma, you want to try the different regimens, whether the Welsh, the modified Welsh, or you want to do the two-step regimen. So there are other medications apart from antifungals and septrin based on the classification of mycetoma that you have. So if you have a eumycetoma, is usually limited, unfortunately, and I pray that the lady doesn't have a eumycetoma on her face, because that's a serious problem. But if it's actinomycetoma, you have many options of antibiotics to use, and the patient should be co-managed with the maxillofacial surgeons and plastic surgeons, probably. So Abdulaziz Balarabe says, I need more elaboration on atypical presentation, as you mentioned varicose presentation. Can dermoscopy help to substantiate? So yes, so usually because you know people who have mycetoma may not present early, or they may have tried several treatments that may have changed, the way in Nigeria, change the appearance of the mycetoma. So it's looking, you are not sure if it is chromoblastomycosis, you are not sure if it is epidermodysplasia verruciformis, a very aggravated type. Those are, so even though it's atypical, it would just look like something else. But what we're trying to say is that if you do see any of those things, you should also rule out mycetoma. So in such cases, the biopsy will probably help, the fungal studies would help, and all that. Then dermoscopy. Well, dermoscopy in eumycetoma, actinomycetoma is still early on. I am not sure, whether you'll be able to distinguish other than the granules, and but I will look at it. I'm not sure if dermoscopy will be useful in distinguishing between the two. But usually a biopsy and culture, and the radiology and all that would be able to distinguish between the two. Thank you. Then Lovet Oladele says, thank you for the presentation. Are there NTD dedicated offices in the states where patients can be referred to and treatments free? Yes, most NTDs are treated free of charge. There's an NTD control program in every state. And usually where you have a reportable or notifiable disease, there's a form that should be filled. So in hospitals where you are a teaching hospital, such cases should be referred to the community health department in that hospital. They are the ones that can, would have access to the form, the IDSR form that are filled, and then they can report it to the state so that the patient can be referred. So usually for those cases, we refer to the community health department, and they will take care of the patient. At the community level, in primary care centers, you can send to the local government. Every local government has an NTD, a DSNO. DSNOs are the disease surveillance notification officers. DSNOs are responsible for reporting notifiable diseases to the relevant health authorities. And once that is done, they will take up the treatment of the patient. In Nigeria, it's important to note, though, that not every NTD is currently being treated in the National NTD Control Program. So some NTDs, the patient may still need to cater for their treatment. As regards mycetoma, I do not think that mycetoma is in the Nigerian NTD Control Program. So the treatment is not likely to be free. Patients may need to pay for their treatment. And that is because it's not very common. So if we make a case for it, if we are reporting more cases and we see that mycetoma is actually more common than we think, then maybe the NTD control program will then take up the management of mycetoma. But to the best of my knowledge, and Dr. Oyewo here, I would like him to confirm, mycetomas is not in the current program, Nigerian NTD control program. So the treatment may not be free. Sorry, let me just try to reduce the size of this. Okay. Okay, other questions here, let me see. Yes, someone is asking, Anonymous, thank you so much for your presentation, asking, could you continue this series and enlighten us more on skin diseases besides those that are neglected? We'll think about it. For this series, we are talking about skin entities, but yes, you are very right that we need to increase capacity on skin diseases. Dr. Gold Olufadi is hosting a masterclass on skin diseases. I would say that you can please sign up for that course. It will be very, very enlightening, and you can learn about other skin diseases. But yes, in the future, we'll look at if there is a need for it. We can have other webinars on other skin diseases apart from neglected tropical diseases. Thank you for that question. Please sign up for Dr. Gold. Dr. Gold, please, can you put in the chat box a link to your webinar, your class, your master class on skin diseases, so that if anyone is interested, they can also sign up for that. It will be very good.
Thank you, Dr. Cole. I'll put it right now. Thank you.
All right. You're welcome. So
how do I send a chat to everybody? I don't know how.
In the chat, there's chat. Yes. So just click on chat. So only the panelists can put something in the chat box, but you should be able to, and everybody will see it, and then they can click on the link from there. So please check the chat box. So is mycetoma among the notifiable diseases reported? Like I said, yes, you can report it under deep fungal infections, but I'm not sure if there's a program dedicated to mycetoma in our current NTD control program. So the person may not get free treatment, but it is important for people to be notified because it is a WHO specified NTD. So we need to make more reports so that the cases can be discussed at the national level, and then they can accommodate them in the current NTD control program. I would like Dr. Oyewo to comment on that, if I am in order. Okay. So all our classes, Sorry, our classes are usually on YouTube. All the webinars are on YouTube. So we'll put the YouTube link as well in the chat box so you can access it from there. We usually don't share the slides because the slides are so many. And, you know, I mean, the number of people registered are so many, and usually to share slides to so many people may not be feasible, but you can watch the recording on YouTube. Sorry, I interrupted you.
Yeah, I can only share to panelists in the chat. It just says send to host and panelists. I'm not seeing where I can share to everyone. So
Okay.
I shared the link in the box.
So just click further down too, and then click on everyone. Okay, try it again and see.
I don't know. I clicked it. All I can see there is panelists. I can't see anything but panelists. I don't know why.
Click further down. Okay, I'll just copy and paste it then.
All right. Thank you. Thank you, Dr. Cole.
All right, Dr. Cole, may I come in?
Yes, Dr. Ewo, thank you.
Okay. Thank you very much, Dr. Cole. Well, there are 20 entities like we know, but in the Nigeria NTD program, there are 13 that are on the program. The remaining 7 still need to be worked on, like Dr. Cole talked about. In public health, the public health importance of the disease at the national level, it goes beyond just seeing it at the facility level. We have to report it if it's a reportable disease, pass it to the appropriate quarters so that would now be looked into. If there's a need to do what is called a pre-task task mapping and all those steps. And when those steps are done, then we'll now move ahead to that level. Where Mycetoma is now among the 13 NTDs on the NTD program, the national NTD program. Thank you.
Thank you very much. Yes, so it is when we see these cases and begin to report them. So yes, even though the treatment may not be catered for by the government, if they begin to get more reports of the condition, then that can be reconsidered at the federal level. So that's one of the reasons why we're having this webinar, is to make sure that these reports, happen, and so that action can be taken on a public health and a national scale. Someone is asking, you mentioned a particular gender that are majorly affected by mycetoma. Can you please explain? Well, the explanation given for why males are more affected is because males are more involved in the farming. Males are more involved in moving around. In areas where you have mycetoma, you find that women are usually at home. They are usually caretakers in the home or in the marketplace. But the men are the ones that are in the farm, tilling the soil, hunters in the forest, and that's why they are more exposed, to the organisms that may cause the organisms in the soil that may cause the mycetoma. So that is probably the only explanation. There's another highfalutin explanation that progesterone is protective in women, but that hasn't been fully elucidated. The major explanation is because it's an occupationally related hazard. So that's that. We do see it in women too, because that in some parts we have people that go barefoot. There are some religions that they go barefoot, so they may be at increased risk of things like mycetoma because they're walking around barefoot, and they may be more exposed to the organisms that cause this problem. Thank you. So I think I've been able to answer all the questions.
Sorry, can I add, Dr. Cole?
Yes, please.
Okay, sorry. I think it's also important for us to use this channel to get to our people. There's this traditional perception to skin deep, especially when it has to do with this neglected tropical disease. You hear this will not be waiting that they treat for hospital. Some of us have had instances of patients who have come home with NTDs. And when you start treatment, they get better a little and they return to traditional homes or to religious homes for treatment. And when they come back, it becomes more terrible. So we can, at least we've seen what it looks like now. When that patient comes to you in the pharmacy saying, I beg, prescribe drug for me, tell the person is beyond you buying a drug. Go see the appropriate specialist. When that person comes to you as a nurse in your nursing home, comes in the nursing home, you necessarily would need to also get things, you guide them appropriately so as not to cause issues. I think that's just what I want to add at this point. Thank you.
Thank you. That's very, very essential. So this looks like the kind of thing that in Yoruba they will say ofani. You know, there's something like an arrow, or they stepped on something, you know, and they feel that
right.
it is a tradition, juju, you know, but it's actually an infection. So a lot of people that will have this kind of problem will probably, as Dr. Ewa said, go to the traditional home first. And we are trying to let people realize that, you know, you should encourage patients to see the doctors and go to the teaching hospital or where you have a dermatologist or an infectious disease specialist, and, you know, to have proper treatment. So, and the treatment of this condition is very long term. This is not something you can treat in 1 or 2 weeks. It takes months to treat mycetoma or Madura Foot. And that's one thing that you need to tell the patient when you see them, that you go to the hospital, but no, don't be tired of treatment. It's not something that's going to go within 1 or 2 weeks. You are going to be on treatment for up to a year. So when you prepare their mind like that and they come to the hospital, they are prepared, they are ready to, they already know that this is a long-term, this is a condition that's going to require some long-term treatment. And that's one of the reasons why we're, you know, doing these presentations, to sensitize and highlight this to health workers across board. So wherever you see the patient, the take home should be that when you see a patient with a swollen foot, where, you know, there's sinuses, it's bleeding, there's pus, and you have like these granules, they could be whitish, they could be black, they could be yellow, they could be red, they could be pink, with pus and bleeding, think of Madura Foot and tell the patient that it is not a spiritual attack or something like that. And it can be treated by a specialist, and refer the patient to a dermatologist. You can start the patient, if you know, in the community level, on some baseline treatment. Usually start with Septrin, but refer the patient for further assessment and treatment. Okay. Thank you. I don't know if Dr. Nafisa has anything to add. Oh, well, we just want to hear your voice.
Thank you, Dr. Cole, for the excellent presentation as usual. It's been very educative. I just wanted to point out, especially to the family physicians or the people, doctors that run the outpatient clinic, that please, when you see this kind of patient, refer, as you're referring to, some will refer to the surgeons first, or only to the surgeons. So please, as you are referring to the surgeons, don't forget to refer to the dermatologist if you have one. Some of these things can be managed without surgical intervention. So let us not be quick to subject patients to amputation or things like that. So don't always think it's orthopedic or general surgery or plastic surgery. Refer to both so that patients will have that benefit of
yes. So amputation should be the last resort, you know. And if there are surgeons among us, they should also invite the dermatologist or infectious disease or microbiologist to co-manage, because sometimes when this happens, maybe they just say, it looks so bad, and they counsel for amputation and the patient runs away, you know, whereas maybe some medical therapy could salvage leg. Don't want to just lose a limb like that. So these are some of the take-home points or lessons that we're putting into that. Thank you very much, Dr. Abdullahi, for that as well. So I think we've come to the end of our presentation for today. Next presentation will be Dr. Oiwo should be taking his endemic treponematosis. So we'll probably have that next, but whatever the next presentation is, you'll get an email. The email also contains the link to the YouTube channel. So if you've not registered, please register so that you receive emails for other webinars. And we want to start promoting that. We hope to have skin health outreaches in different communities. So if you are in a community, that you would be interested in being a part of a skin health outreach and being the anchor, the person that will arrange it to, because we can't be everywhere, please let us know. So at the end of our webinar series, we're going to have, kind of like a practical, in quotes, skin health outreaches to various communities where, we think we'll be able to, help people to diagnose and treat or refer skin diseases, particularly NTDs, appropriately. So please let's know about that. Thank you very much. Can just have a word from everyone as we close. Dr. Go, Dr. Ewo, Dr. Abdullahi. Thank you.
Thank you so much, Dr. Cole, for the amazing presentation as always. And I'm sure that a lot of people have gained tremendously from all these presentations that we've been doing. And if not being able to treat, I'm sure they're able to recognize a lot of these skin NTDs now and refer as appropriate. So I'm sure that we have done a good thing with this series that we are doing. So thank you for the wonderful presentation as always. Have a lovely evening, everybody, and have a good week.
Thank you.
Thank you, Dr. Cole, for the excellent presentation. I want to thank every one of us for coming, the panelists and the participants. Pardon the background noise. I'm on transit. I want to also thank members from the Federal Ministry of Health who are here with us. Myself, Mr. Polayo, I think he's left, and I know there are one or two other people who have joined. So we are quite grateful to them. And so the good news is go share the good news. Like Dr. Gold said, even if you may not know how to treat, once you have seen it, stop telling, disabuse people's mind when they say, Komole or in Edo, they say back. Tell them it's not traditional. Go to the hospital so that they will have treatment. Thank you.
Thank you very much. Thank you so much. So have a pleasant week, everyone. Dr. Abdullahi.
Thank you. Bye-bye. Enjoy your week.
Thank you. Bye, everyone. Thank you, NDBC Kenneth, for that. I'm just reading it before we closed. You spoke about prisons, yes, and skin diseases are very prominent. Yes, I'm aware. I also do some skin health outreaches to prisons, and it's always an eyesore. We try to do our best. We will look into that further for our colleagues in Enugu. I'm in Lagos, and I do visit some prisons with my church ministry once in a while. So yes, I think it's very important for us to have some public health intervention to prisons with skin diseases. Thank you very much for that. All right, thank you, everyone. Thank you. Have a blessed week ahead. Bye-bye.